All right, well, we might get started because we do have lots to get through. So welcome everyone to this webinar on delivering quality paediatric cancer survivorship care. My name is Tegan and I'm a project officer with the Australian Cancer Survivorship Centre. And I'm really pleased to be facilitating this webinar today alongside Hannah Pring from PICS. Hannah, do you want to just quickly introduce yourself to everyone?
Yep. Hello. I hope you can all hear me okay. My name's Hannah Pring and I am a project lead at the Paediatric Integrated Cancer Service.
Thanks, Hannah. So I'd just like to begin by acknowledging that I'm hosting this meeting from the lands of the Wurundjeri people of the Kulin Nation. I also acknowledge the traditional owners of the lands on which you all work today and pay my respects to elders past and present and to Aboriginal and Torres Strait Islander people participating in this meeting. I would also like to thank Hannah Pring and Justine Carter from PICS who have been really instrumental in organising this webinar, as well as thanking Royal Children's Hospital for allowing us to present this webinar in your usual education time slot. And I know that we have others that have also joined from other sites around the state. So welcome to those of you who are not typically in this meeting. And also a special thanks to some consumers that have also joined us today. Meg Rinderman, OAM, and Kylie and Tilly Pretty, whose newly released survivorship story will share with you later on. So this webinar has been designed to increase your awareness of survivorship care, and our overall aims are to give you a bit of an insight and an overview into some of the key elements of survivorship care in the paediatric context. We'll discuss some common issues and long-term and late effects experienced by survivors of childhood cancers, and also some of the complexities associated with transitioning from a paediatric to an AYA to an adult cancer service. We'll also then look at some resources that are available to survivors and carers, as well as health professionals that may be of interest to you. So the session today will go for 60 minutes and we have a very full agenda with some really interesting topics and some wonderful guest speakers that have joined us today. So we'll start off hearing from Dr. Peter Downey presenting an overview of survivorship care as it relates to the paediatric context. We'll then hear from Dr. Quinn Nguyen and she'll speak to common issues and long-term effects as they relate to growth and puberty. Following that, you'll hear from Dr. Yasmin Jai Singh, who will speak to issues relating to fertility and reproductive health. And our final guest speaker today is Dr. Jeremy Lewin, who will be discussing transitions. Hannah will update you on the PICS new model of care, and then we'll finish off looking at some of the resources available to you. So before we get into some of the content, we've just got a couple of quick polls just to get a feel for who's in the room today and what your current awareness of survivorship care is. So I'll get Amy to bring up this first poll. What is your profession? Just interested to know the type of people that we've got joining us today. So I'll just give everyone a moment to complete that poll just to see who we've got in the room. And then we might get some results pop up. Great, thank you. So a bit of a mixture, some nurses, allied health, medical oncologists, paediatricians, and some into the other categories. So thank you everyone for that one. We've now got another poll. How would you rate your current knowledge of survivorship care from low to high? And I guess we're hoping that, over the course of this webinar that this may increase. And I guess we would also expect to have, a wide range of levels of knowledge joining us at the webinar today. So again, give you a moment to complete that one. Great, so a good range from low, intermediate, is probably the most popular, through to high. So that's really great to see. And I guess if your current knowledge is sort of in the lower end of the spectrum, then, this will be a really great webinar for you to gain some more of that information. And if you're kind of in the high spectrum, of course, it's always a great reminder and opportunity to connect with colleagues on information in this space. So I'd also like to introduce you to the Australian Cancer Survivorship Centre. This is the organisation that I work for, and I'm sure some of you are already quite familiar with us. So we call ourselves the ACSC, and we're a unique service based at Paediatric in Melbourne. We launched in 2010 with funding from Paediatric, the Victorian government, and previously philanthropy services. So receiving that funding from the government means that we have a statewide remit. So we have a dual focus on improving care and outcomes for survivors at Paediatric, and also across the whole state of Victoria. We're a non-clinical service, and our vision is to optimise the health and wellbeing of cancer survivors and their carers. Our strategic plan outlines 6 key focus areas, with some of those being to provide information and support to survivors and their carers, to provide survivorship education and training for health professionals, and also to support improved models of survivorship care. This particular webinar is part of a broader project and has come about from a broader project titled the Embed and Spread Optimal Cancer Survivorship Care Across Victoria project, which is funded by the Department of Health and is being led by us at the Australian Cancer Survivorship Centre. And funding for this project is part of an ongoing commitment from the Victorian government to improve how Victoria delivers survivorship care. So this project has involved engaging with 20 cancer services across Victoria, of which the Royal Children's Hospital was one of. So over the last few months, we've been delivering survivorship webinars to these 20 hospitals. And obviously for this particular webinar, we've collaborated with PICS, given their expertise in this space. So we're really pleased to be presenting alongside them today. As well as these webinars, another key aspect of this project has been a baseline site survey, which was completed by each of the 20 individual hospitals providing cancer care across Victoria, obviously including Royal Children's Hospital. So we thank PICS and Professor David Einster at Royal Children's Hospital for their support on this survey. And, obviously we recognise that that particular survey only captured data from the Royal Children's Hospital, so it doesn't necessarily represent the other paediatric services across the state that you may work in. What's also been happening simultaneously is that PICS have been doing their review and update of the long-term follow-up program, which Hannah will update you on later. And from our survey and this review, we kind of realised that there's a lot of common themes across those 2 pieces of work. So Hannah will share some of those common themes with you in her presentation later on. So my final slide here is just to give you a broad kind of overview of the term survivorship and survivorship care. So many organisations and institutions say that an individual is considered a cancer survivor from the time of diagnosis through the balance of their life. And this includes people who are receiving initial maintenance or ongoing treatment, or in the recovery or post-treatment phase. And typically we would say that family members, carers and friends are also considered to be a part of that survivorship experience. Although this is how many organisations define the term cancer survivor. We know that,
I can see myself at last. Yeah.
I think Peter's just joined.
Thanks.
Okay, go. Yeah, so as I was saying, we know that many people don't necessarily relate to the term cancer survivor, and there is other language that people may prefer to use. The term survivorship care is commonly also referred to follow-up care, and I guess survivorship care should provide a focus on the health and wellbeing of a person living with and beyond cancer, addressing that full patient experience, from diagnosis right through to end of life. And whilst most of the resources and models of care focusing on survivorship are concentrated on the post-treatment phase, we know that the principles of survivorship care and survivorship do apply at all stages of care. So that's all from me as an introduction to this webinar. I'll get Hannah to pop her camera on now and she'll give us an introduction to Dr. Peter Downey, our first speaker.
Thank you, Tegan. So I would like to introduce our first speaker, Dr. Peter Downey. I'm sure most of you know that Dr. Downey is the head of Paediatric Haematology Oncology and director of the Children's Cancer Centre at Monash Children's Hospital. And he's also a consultant at the RCH, a senior lecturer in the Department of Paediatrics at the Monash University and Medical Director for the Victorian Long-Term Follow-up Programme. He's joining us today to provide an overview of survivorship in the paediatric context. I'll hand over to you, Peter. Hopefully you're okay with to share your screen.
Thanks, Hannah. I don't know that I can actually, but I'll give it a go. Is that working?
And then if you just go to presenter mode, that's perfect. Almost there. Here we go. Perfect. That's great. Thank you.
All right. I want to make, well, I'm going to be pretty quick through this because clearly if I was to talk about childhood cancer survivorship, I could talk for 3 hours. You know, there's a lot of data to go through, and in fact, that's probably not the point of this, but actually maybe just to talk about what we're doing here in Victoria. Childhood cancer survivorship care in Victoria is actually, it's a government initiative, and it's a Paediatric Integrated Cancer Service that runs it. So it's not actually institutional based, it's statewide. So next slide. What's the background to this? So if we look at Australian childhood cancer facts, the 5-year survival currently is around about 83%. And the reason why that's important clearly is because childhood cancer survivorship means that for children who have been off treatment for more than 5 years, they have a 98% chance of survival. So that's recent data, meaning that it's about 5 years out of date now. The cancer death rate in children has decreased by 60% in 30 years, which is pretty well my practicing lifetime. So this becomes more and more important. In Victoria, there's about 220 children that are diagnosed with cancer under the age of 17 every year. The bulk of those are patients that have got leukemia. If you add the leukemias and the lymphomas together, it makes up about 50%. 25% of those are brain tumours. The survival in 1966 for that cohort was 20%, 1976, 50%, and now 83%. And so if you look at textbooks that go back to that era, curing cancers is not without consequences. And this is a new era of medicine, which is, I don't like the word late effects, but it's really about making sure that children that survive cancer have the best possible chance of good health. Children diagnosed with cancer are sometimes exposed to very rigorous therapies and often early in life. And so children that are still developing, infants, etc., they can have late effects of therapy that may not actually appear until they're either hitting puberty or even into adulthood. And so that's why this is important. If we look at the CCSS, which is the Childhood Cancer Survivorship Consortium in the US, and they've done 2 cohorts from 70 to 86, and then another cohort that goes up until the early 2010-11 era. And there are actually more than 50,000 people that they can actually study up until now. But in the early CCSS cohort, it was 21,000 5-year survivors. And in the overall cohort, there was an 8-fold excess death rate. And what's important to know, in fact, is that disease recurrence is the single biggest cause, accounting for about 60%. And then cardiac, pulmonary, second cancers were next, and other treatment-related complications. But there was no increase in accidents or suicide, bearing in mind that this is American data. What do we need to do when we're looking at late effects of childhood cancer? We need to look at all of these things. We need to look at stature, scoliosis, avascular necrosis, soft tissue hypoplasias, dental problems, learning difficulties, hearing difficulties, potential infertility, thyroid dysfunction, cardiomyopathies, other problems with the heart, hepatitis, pulmonary fibrosis, chronic enteritis, and second cancers. So it's a fairly comprehensive list of things that we need to be checking for. And what do we need to do when we see these patients in the clinic? Number one, what's the previous treatment? What was the surgery? What was the X-ray therapy? What was the dose of radiation? Tell us about the chemotherapy, what the doses were, what the cumulative doses were. Is there a history of intercurrent illnesses since you've come off therapy? do a full systems review, a medications review, and then an educational status review. What was the grade completed? Was there special education required? Have you had an IQ test? What was the result of that? What are areas of weakness that we can perhaps concentrate on? And when they're a bit older, we need to find out a little bit about employment status, and we need to know about insurance coverage. Is it an individual policy? Has it been done through your parents? Is it something that's been an issue? Has there been difficulties getting insured? And does it depend on age, partner, marital history, menses, libido, sexual activity, contraception, pregnancies, patient or spouse, social history, drug use, risks, and time alones? Time alone is important because we need to start doing that with teenagers when they're around about 14 or 15, because at the end of the day, it's important that they take control of the management of their own health. The top 5 patient-reported outcomes that we have come from our own questionnaire are these: school, tertiary education, TAFE or work, moods or behaviour, eating, appetite, sleeping and weight. What we do, in fact, before we open the clinic is that we send out a pre-clinic questionnaire to the families and they fill that out in advance so that we can then target what's important when they come to the clinic. The long-term follow-up program has been established now since 2007. The first clinics were in May 2008. We started running them on a more of an ad hoc basis, but over the last 5 years, we've been running somewhere between 120 to 130 clinics per year. There have been around about 600 to 700 appointments per year. There have been nearly 2,000 children and adolescents that I've seen through, or we have seen through the clinics, and there are currently just under 900 children that are currently active through the clinic. It's really important that we think about risk stratification when patients come into the clinic. All referrals must be triaged. There must be a knowledge of disease and treatment, complication, side effects, what age was the child when they had their treatment. And as I mentioned, we have the pre-clinic questionnaire. The service model looks a bit like this, where if we think about diagnosis involves risk assignment and risk stratification for therapy, particularly in paediatric cancer. And then treatment is designed accordingly. The child goes into remission, treatment continues, and then they get to the end of therapy. There's ongoing disease surveillance, which is usually for 2 or 3 years, and then referral to long-term follow-up. And then there's a needs based on risk assessment and intensity of treatment that divides up into low risk, medium risk, and high risk. And if you think about it like a triangle, you've got most of the children will sit in the low risk and to the intermediate risk. But really what's important is the pointy end of that triangle. And it's those children that really need the multidisciplinary care that's required for childhood cancer follow-up and then referral into tertiary settings. And I'll talk about that in a minute. So that's an appointment and transition system where you can see the referral received, and there's clinical criteria that we go through. And then we have an initial long-term follow-up clinic that's based on that risk stratification. The subsequent clinics will also be based on that risk stratification and whatever is found at that first appointment, because the risk stratification may not be correct. Then there will be transition clinics, and I've asterished those because there's certainly an advantage in running a transition clinic because you'll capture the patients more easily and the transition will work a lot better. And I've seen this model overseas work quite well. And then the transition will either be to a tertiary centre, a regional clinic, or into primary care. There is absolutely no doubt that the majority of childhood cancer survivors are best served by their needs in primary care and not in tertiary care. And there's lots of reasons for that, which I can or can go into if you wish. So risk stratification, the ideal would be something like this. A neuro-oncology multidisciplinary clinic would be an oncologist, nurse coordinator, endocrinologist, rad-onc, speech therapy, OT, physio, neurology, dietitian, social worker, a neuropsychologist, and an education person, a teacher or somebody that's facilitating education. A bone marrow transplant MDT would be sort of similar. And then you would then have other multidisciplinary team group professionals that would be in there: oncology, CNC, endocrinologist, dietitian, social work. Fertility needs to be considered in this group, as it does in the other groups, but particularly in this more complex group. At Monash, we run a fertility clinic once a quarter, which is specifically targeted for those children that need it. And then there are standard clinics, biannual clinic, a regional clinic, and then a regional telehealth. And you can see that the bulk of these ones, where we might have, other mental health or social worker or dietitian that could also be referred out. This is basically a snapshot of the current LTFP clinics that we've got: neuropsychology, regional transfer, telehealth, etc., going back from 2009. And it really basically shows the growth that we've now reached this point here. The original plan with the long-term follow-up system was that by 5 years from its establishment, we would be seeing 80% of the diagnoses from that previous 5 years, and that's about where we are. And the idea would be that you would then have patients that are coming into the long-term follow-up system in paediatrics and then being transitioned out, so that we've got a steady number. That hasn't happened because, in fact, the birth rate went up by about 10,000 a few years ago, and for every 10,000 newly born babies, that's an extra 45 cases of childhood cancer that we would see within the next 3 years. And unfortunately, that's what's been happening. The patients receive in the clinic a patient passport, some clinic information, general healthy living information, treatment summary, including cumulative doses of drugs, a roadmap, and a time point plan for ongoing health surveillance. What's important about this picture, in fact, is that you can see that it's me. And this was when we were launching the program and advertising it. And this was a 16-year-old boy who we were getting to take control of his own care, etc., and told his parents to go and wait outside. And this was time alone. And here I am giving him his passport and all the information that he needed for health surveillance that he would carry through into his adult life. And as he's going, he gets up and says, "See you later, it's really fantastic." And he just left that sitting on the desk. And when I went out to speak to him, "Did you leave anything behind?" "No, it's all good." So it gives you an idea about some of the complexities that we have with our teenage patients, and that while we want them to take command of their own health, we need to guide them to do so. I'm just going to flip through these slides because these are some of the issues that we face in long-term follow-up. And it's about quality of life, fertility, psychological outcomes, bone health, cardiovascular health, risk of stroke, second cancers, utility of interventions. This is really important. Whenever we find these issues and we want to put an intervention in, how effective is it? Do we know that it works? And I think that's where the research really needs to be concentrated. And where we are at the moment for our future directions, that in my opinion, screening must be risk adapted. You cannot do this otherwise. And the knowledge of risk is very challenging. So it's radiation versus the cumulative effects of chemotherapy versus surgery, and not one size fits all. It's a constantly changing feast in a growing population. We're changing our therapies. Some of them are more intensive, and so that creates issues for those children as they get older. We need to evaluate the interventions, behavioural, educational, physical, and preventative. I think it should begin at the end of active therapy, and the referral should be made into long-term follow-up then. We don't need to see the patients, but we need to know about them. And then there's this influence of genetic profiles on susceptibility as well as lifestyle that we're starting to discover in medicine, so-called precision medicine. The shortcomings are related to a lack of knowledge about long-term follow-up from patients and primary care physicians. And we need to be able to deliver standardised care. It's really about education into the community about what long-term follow-up means for various patients, depending on their disease and their therapy. There are therefore shortcomings of the healthcare system. Transition education, data collection, it's costly. You've got to train people. You need people to have a career development, and there needs, in my opinion, to be a nurse practitioner model to facilitate this. We need to embed long-term follow-up strategies into protocol developments, such as quality of life, new therapeutics, modification of therapies, protons, etc. It needs to be done up front. As I said, it's costly. To run a proper long-term follow-up multidisciplinary clinic costs about $1,200 per patient per session, and it's understudied. We know that routine annual echo, for example, is more cost-effective than any other long-term follow-up screen. But when Kevin Offinger looked at the guideline tests that were put out by COG, 90% of them were actually redundant and so not cost-effective. Do we know that any of the programs that we deliver are beneficial? Do health risk promotions, behaviour modifications work in this population?
I'm so
Finally,
sorry. Oh, good. Are you sorry? So sorry, Peter, to jump in. I was just saying we're just a little bit close to time, but you were just saying finally, so I shall let you.
I'm just finishing, Hannah.
Yeah, no problem.
The concept of survivorship frailty. There are numerous studies documenting frailty in adult survivorship, particularly in older groups. And we're starting to see that same phenomenon in 40 plus childhood cancer survivors. And maybe molecular and epigenetics will play a role as well. So in summary, with the time constraints to really educate about long-term follow-up, 10 minutes is far too short, but it's a mature statewide service. It has access to all survivors of childhood cancer. It's based on a risk stratified clinical structure, and it includes a multidisciplinary medical nursing and allied health staff model. The take-home message, though, is that the vast majority of children that are survivors of childhood cancer are healthy and well and will grow and develop normally. Thank you.
Thank you so much, Peter, and sorry to jump in there. Yeah, thank you for that really helpful overview. I'm now going to welcome and introduce our second speaker. That's Dr. Quinn Nguyen, a paediatric endocrinologist at Monash Children's Hospital and researcher with a special interest in the late effects of childhood cancer treatment, fertility preservation and reproductive health. Quinn is also a clinician with the Victorian long-term follow-up programme and is joining us to discuss common issues and long-term effects relating to growth and puberty. So over to you, Quinn.
Thank you very much. I'm hoping everyone can hear me. I'll say up front that this is not going to be comprehensive because I've been given 7 minutes. So I'll do my very best to give you an overview. So this is a very simple schematic slide that shows the main influence on linear growth throughout childhood. Genetics and nutrition obviously are fairly static under normal circumstances to ensure height gain. And in terms of hormonal influences...
Sorry, Quinn, I'm not sure we can see your screen. Peter, are you... yes, are you able to turn off your camera? That might help. Thank you. And Quinn, are you able to just share again, perhaps? Perfect. We get it. That's lovely. Thank you.
All right. Probably nobody needs that title slide. All right. So genetics and nutrition, as genetics obviously dictates the genetic potential in terms of height and growth. Nutrition is essential to ensure that genetic potential is reached. From around the age of 2 or 3, growth hormone becomes a critical hormonal determinant of normal linear growth. And at the age at which a child reaches puberty, the pubertal growth spurt is initiated and sustained by the sex hormones, in particular estradiol, which acts on the epiphyseal growth plates to rapidly accelerate growth over a 2-year period, but then fuses the growth plates and ultimately stops growth altogether. So what we not typically see is slow but steady growth through mid-childhood, just a brief slowing before the pubertal growth spurt starts. And then we see this upsweep here during the pubertal growth spurt, and then epiphyseal growth plate fusion leads to a levelling out at final height. And aside from genetics, all of these other factors can be affected by childhood cancer treatment, and in particular by cranial radiation, which will be my main focus today. And that is because it accounts for the bulk of the endocrine morbidity that we do see, and it causes multiple complex problems. And I will touch on other things very briefly, but don't have time to go into it in detail. So radiation damages neural tissue, fibrosis leads to hypopituitarism, progressive atrophy of the hypothalamus and pituitary leads to delayed onset endocrinopathies. This is determined, so the toxicity of the treatment is determined by the total dose of radiation given. And you can see here that there is a difference in sensitivity between the hypothalamus, which is damaged at lower levels of radiation, versus the pituitary at higher levels, and in particular multiple pituitary hormone deficits, which emerge at high dose, mostly at high doses. And the second thing that determines this is the fraction size. And if you have more time between fractions, you have time for tissue repair. So fewer fractions and a shorter total duration of radiation treatment leads to worse endocrine outcomes. As I've shown you, the hypothalamus is more radiosensitive than the pituitary. And the pituitary shows a typical progression in affected patients to multiple pituitary hormone deficiencies over time. Typically, growth hormone goes first, followed by the gonadotropins, ACTH, a thyroid stimulating hormone, and then finally derangements in prolactin. Talking about growth hormone deficiency specifically, the hypothalamus normally produces growth hormone releasing hormone here, which stimulates the pituitary to produce growth hormone, which then exerts its tissue actions mostly via IGF-1. Cranial radiation can damage both of these glands, and therefore we can have a loss of growth hormone, but also of GHRH. And these two diagrams here are just to show two different studies which demonstrate that it is a dose-dependent issue here. This is from a review by Stephen Shallett in the 90s. And then this here is quite a nice little diagram. This is showing incremental increases in conformal radiation treatment from 10 grays here down to 60 grays down here. And on the y-axis here is the peak stimulated growth hormone level that we're able to induce on testing. You can see a very strong dose-dependent relationship there. To go through normal puberty very briefly, the hypothalamus produces, so normal puberty, is driven by the pulsatile secretion of gonadotropin releasing hormone from the hypothalamus. This stimulates the pituitary to produce LH and FSH, which act on the ovary to stimulate the production of estradiol and progesterone from the granulosa cells, and on the testes to produce testosterone and induce spermatogenesis. And the earliest changes of true central puberty that we see in children, in girls, are breast buds, and in boys are an initial increase in testicular volume. And often the rest is just noise. For some definitions, precocious puberty is still largely defined as being breast development below 8 years of age in girls and testicular enlargement below 9 years in boys. And delayed puberty is no breast development above the age of 13 in girls and no testicular enlargement above 14 in boys. In terms of pubertal problems, and I am again going to focus mostly on cranial radiation, central precocious puberty is a common consequence of cranial radiation, particularly in earlier childhood. And this is because of a disinhibition of that hypothalamic pulsatile GnRH secretion. And that can lead to rapidly progressive central precocious puberty with a very poor height outcome because of the premature fusion of epiphyses. And it's an important practice point to know that this can be exacerbated by concurrent growth hormone deficiency. And a common pitfall is that growth hormone deficiency can be masked by early puberty due to that sex hormone mediated growth spurt that we do see in puberty, whether it's precocious or at a normal age. These patients can also get late pubertal failure and arrest. In particular, the patients who have had central precocious puberty with high dose radiation are at increased risk of later losing their gonadotropins and having hypogonadotropic hypogonadism, or can have delayed puberty due to the same process. And then, of course, there's the effect of treatment, including TBI, alkylators, and pelvic irradiation, causing primary gonadal failure. And I won't talk about this because Yasmin will, but just briefly, amongst ageing survivors from the CCSS, we know that women are at 6 times the risk of premature ovarian insufficiency, and men have a greater need for testosterone replacement in adulthood. So indications for endocrine referral, broadly speaking, I think of it as treatment-based or based on clinical concerns. Treatment-based, any patient who's had any radiation to the head should be referred early, and that includes cranial radiation for leukemias and total body irradiation for bone marrow transplant, as well as craniospinal radiation. Any patient with a history of high-risk gonadotoxic chemotherapy, which Yasmin will speak to more shortly, and these patients should be referred at the age of expected puberty, so around 10 years in girls and around 12 years in boys. And a parenthetical addition here is intracranial lesions, which have a higher risk of hypothalamic pituitary axis impact, such as optic gliomas, pineal tumours, and so on. And then clinical indications outside of that, obviously any signs of precocious or early puberty, or failure to progress or go into puberty. And this is where careful pubertal staging is really critical. And it's really important that the primary physicians for these patients can accurately stage puberty or refer to somebody who can. And in terms of growth, we would like people referred if they're crossing height centiles over about 12 months. But it is important to note that nutrition also needs to be optimised, and that cranial radiation in particular can cause issues for appetite and weight and poor weight gain. And this needs to be ensured because height will follow weight. So going back to that first slide, in summary now, genetics stay static for our childhood cancer patients, but nutrition can be affected by treatment. They can have growth hormone deficiency due to cranial radiation, and they can have multifactorial issues with puberty, including early rapid puberty and late pubertal failure, plus or minus the loss of spinal growth from spinal irradiation. And this can have compounding complex effects on growth and a reduction in their final height, as well as significant effects on their quality of life. I'll leave it there because I think I've run out of time. I just wanted to acknowledge Margaret Zachrin, who helped in the preparation of these slides.
Thank you very much, Quinn. I will now introduce our third speaker today, which is Associate Professor Yasmin Jayasinghe, Senior Research Fellow in the Gynecology Research Centre at the Uni of Melbourne and a gynaecologist at the Royal Children's Hospital. She chairs the Fertility Preservation Task Force in Victoria and the Australian-New Zealand Consortium in Oncofertility. She's on the Best Practice Committee of the Global Oncofertility Consortium and is joining us today to discuss fertility and reproductive health. Thank you, Yasmin.
Thank you so much. It's such an honour to be here with the long-term follow-up team, and thank you to the Australian Survivorship Centre. Today I'm going to be talking about reproductive survivorship, and we know that it's cited as one of the most important unmet needs for survivors. However, we also know that while it should start from diagnosis and continue right through to, into the long term, we know that there are differences in provision of fertility care and fertility preservation at diagnosis. This is very manageable, but all it means is that there will be cohorts of survivors that we see with quite differing needs. Our honours students have been doing a longitudinal study on decision regret and acceptance of fertility decisions over time. And what we found over time is that actually, rather than issues around fertility preservation, the key issues are around survivorship now. And so it can be something as simple as, I'm not sure where to be seen, concerns about regret about potentially not choosing fertility preservation. If she isn't able to have a child when she gets older, I will regret it, but it was too much to do at the time. Another parent saying it was the right decision at the time, but I am disappointed with the follow-up care. There's too much segregation between fertility and cancer care. We have no idea what's happening with my daughter's tissue. I was thinking of phoning hospitals and IVF centres to find it. And then another patient saying, I've been told that the risk to fertility for my daughter was actually low and she didn't need to undertake fertility preservation. And now I'm worried that we did a procedure and the risk of the procedure may affect her residual fertility. So I think, the main point here is that reproductive survivorship really isn't a checkbox and, it should be integrated into surveillance and long-term follow-up. And it's not really just fertility alone. When we look at prevalence of reproductive late effects, you can see here that ovarian failure, testicular failure, they are prevalent. But actually things like radiation-induced vaginal stenosis or uterine injury or genital graft versus host disease as a result of allogenic stem cell transplant and sexual dysfunction are just as important. So it's really important to take a multidimensional approach to reproductive care and using adolescent health principles, as Peter explained before. Often we would try and ask for permission to address some of the sensitive issues, knowing that the young person isn't quite ready sometimes and isn't quite on the same page as their parent, for example, to discuss these things. During a gynecology consult, we may discuss any of menstrual management, preventive health, such as STIs, contraception, risk-taking behaviours, but also ask permission to discuss fertility, evaluate endocrinopathies, and explore sexuality and identity, as well as screen for graft versus host. Asymptomatic patients can be screened once a year, but if they're symptomatic, we would like to generally see them every 3 months or so and start some immunosuppressive treatment. The most pressing issue for parents and young people tends to be fertility, in the sense that not knowing fertility status is a huge concern for them. And we do know that, childhood survivors are 40% less likely to conceive compared to controls, but really the risk is very variable. For some patients, the risk will be negligible, and for others, it'll be very high. Fortunately, the Global Consortium has now published some very streamlined risk tables to predict infertility risk for females and males. And it's similar to what we had before, with low risk being less than 20% and high risk being greater than 80%. And the tables are similar for females and males, except you will note that males are far more vulnerable at a younger age and with lower doses of alkylator, and that's because of damage to the spermatogonial stem cell niche, which produces sperm later in life. When we look at older male survivors, we know that reproductive and sexual health concerns are very important for them, as important as they are for women, and they include issues around fertility, testicular size, and sexual function. We know that azoospermia can occur within a few months, and time to recovery may take even 3 years. And we can see DNA breaks in sperm for 2 years or so. So generally, we recommend deferring childbearing for at least 12 months after cancer treatment, recommending routine semen analysis at 12 months and gonadotrophin testing as well. Some boys might have had testicular tissue preservation, and for those children, it's very important to update them. And really, it is considered an experimental procedure. There has been a live birth in primates, but we haven't matured sperm in children. But often adult survivors don't know where the tissue is stored and where to find it. So it's really important to keep them updated about where that is, how long the tissue can be stored for, which is around 20 years. They'll need to ask for an extension thereafter. And conditions around discarding tissue. And this includes things like, for example, if the child passes, that tissue has to be discarded. And after 20 years, that tissue has to be discarded if the lab can't contact the family. For girls, you'll see that the infertility risk, while we try to prognosticate, it's not an exact science. And this really relates to underlying ovarian reserve. Women are born with a hugely varying amount of eggs. And for those with a high ovarian reserve, treatment will cause acute ovarian failure and reduce egg counts. But afterwards, there might be enough eggs for recovery to occur and temporary ovarian function to continue for some time before premature ovarian insufficiency sets in. There is a window of opportunity for fertility preservation after treatment in these patients. So how do we assess this? There's been a lot of talk about anti-Müllerian hormone, which is produced by growing follicles. These levels decline very sharply with gonadotoxic treatment. They do recover post-treatment after a couple of years and then decline. But however, we really don't have a gold standard fertility test. And ovarian monitoring after treatment, there's really no recommended standard that everyone can agree on. Periods aren't a good sign that there's good ovarian function. You can have ovarian decline in the background. And generally, we would recommend an FSH, LH, and estradiol. And while AMH is not rebatable, more centres are doing this now. And we would do this from around the age of 10 years of age. So an elevated FSH and a lower AMH may be an indication for referral to a reproductive endocrinologist, but I would be very, very careful with interpreting that result, as you don't know where on the curve they are. Low AMH is not a sign of reduced fertility. It's a sign of response to IVF treatment. With respect to pregnancy, we would recommend delaying natural conception for around 6 months after treatment to avoid the risk of mutagenesis, and we wouldn't recommend collecting eggs for around 6 months. Having said that, fetal abnormalities haven't been seen. And we generally quote a success rate or a live birth rate of 4.5% per egg collected. So you'd want at least 20 eggs. there are some young women who will have had ovarian tissue preservation. They should know that this procedure is no longer considered experimental. However, it still has low efficacy. So there have been about 200 births so far, but only 2 from tissue collected from children. The actual live birth rate is about 25% per woman who has the tissue grafted back into her body. In terms of consequences of radiation, we know that high-dose radiation can increase pregnancy complications. And we are wary about pregnancy in the context of uterine radiation, and we would recommend referral to pre-pregnancy counselling. More work is being done on a uterine transplant now as perhaps something that can be offered to women who have received radiation. There have been about 70 uterine transplants worldwide with 20 successful live births, but very, very high morbidity associated with that. I just wanted to close with something that one of my patients raised with me, and talking about fertility. And this was a non-cancer patient, and now that she did have a child, she described, her emotions being in waves, and then eventually she became really angry, and she described herself as eventually becoming, accepting the situation, but what she really wanted was to be the last figure there, the circle, and feeling complete. And while we can't prevent all adverse outcomes from occurring with respect to reproductive health, it is our duty of care to do as much as we can to inform families and make sure that they're making the right decision consistent with their own values. Thank you so much.
Thanks so much, Yasmin, for that really insightful presentation. I'll just introduce our last speaker now, Dr. Jeremy Lewin, who is the Medical Director of On-Track at Paediatric, Victorian Adolescent and Young Adult Cancer Service. A medical oncologist by training, his areas of expertise include sarcoma and genitourinary malignancies. Jeremy provides medical leadership for On-Track at Paediatric, aiming to ensure quality care for young people, a statewide professional education program and targeted clinical research aimed at addressing the major health concerns of young people and their families. Just before you start, Jeremy, I just want to let everyone know that we probably will run 5 or so minutes over time, so apologies for that. But yeah, take it away. Thanks, Jeremy.
Thank you so much. I acknowledge that we're running a little bit late, so we'll certainly try and cut a little bit more time. So I am just going to get straight into it. My focus is going to be on perspectives on transition to adult healthcare outside of the long-term follow-up clinic, and really has been highlighted, transition with the oncology sector is important really to ensure a process that supports quality care for young patients with a history of cancer. I think the approach to transition and models that facilitate transition really need to consider a number of key aspects. And firstly, we have to acknowledge that there's a number of traditional time points where patients may need to move across the sector, and each of these may alter the approach that you take. So certainly it can be done prior to active therapy, or rarely during acute or chronic treatment delivery, such as maintenance therapy. It can occur at the end of treatment, including monitoring the acute effects of treatment delivery or disease surveillance. Or lastly, and most commonly, is where people are transitioning for monitoring of late effects and survivorship. However, all of those key times are really driven by their relationships to treatments. And there are a number of other key factors which are really important to consider about timing for transition. And these include an assessment of the totality of the individual, including both the chronological and developmental age, the extent and complexity of their comorbidities, the spread of clinician expertise across the paediatric and adult sector, in addition to the existing networks with primary healthcare, established health system pathways, and lastly, the availability of resources. So it's really in factoring these key considerations that forms a basis for understanding as to how we can enable this risk stratified or risk adapted approach to transition that ensures that the appropriate levels of supports are provided as individuals move across the health system. I think I just want to highlight some aspects related to location of care, which is really relevant for older adolescents, because there's certainly, in deciding upon location of care, you have to consider a variety of aspects which I've mentioned previously. but also where they are in their development and an understanding of the expertise and treatment opportunities that sit across the sector, the lower age eligibilities of the health systems that we sit in, and the equal comfortabilities of the health system that you work in. So for example, a mature and autonomous 17-year-old with a new cancer diagnosis without comorbidities requiring limited outpatient chemotherapy treatment may require vastly different supports through treatment, survivorship, and late effects surveillance compared to a 16-year-old with extensive prior cancer history, multiple relapses treated with high-dose chemotherapy, and significant ongoing complications. Ensuring that individuals are in the appropriate location, considering these factors, may actually potentially avoid some of the difficulties that we see within the transition process. As many are aware, traditional adult-based systems, when developed without youth-appropriated services, may create additional barriers for young people. Adult systems tend to expect a high level of independence, autonomy, and self-management, which may be out of keeping with their developmental age. And occasionally the focus on the individual-based decisions that we teach in adult-based training can occasionally be quite confronting for young people and their families. In addition, adult systems often utilize the ambulatory setting where there is less specific developmental appropriated supports or develop dedicated youth-friendly spaces to what patients and their families have previously been used to. The principles and frameworks of successful transition are increasingly being described in both adolescents with cancer and those with chronic medical conditions. And when done well, can be empowering, both to survivors and may improve outcomes. However, given the inherent differences in the structure and culture of paediatric and adult healthcare, the transition can put the growing rates of paediatric survivors at risk of healthcare disengagement and being lost to follow-up. And this is really of importance, as Peter has acknowledged, in terms of new health issues which may only arise within the transition period or only may become apparent after individuals are embedded in the adult sector. Importantly, knowledge gaps in both childhood cancer survivors and their healthcare providers, predominantly adults providers, have been well documented, which may create additional barriers and compound the risks of not detecting late effects, as well as increasing the risk of being lost to follow-up. So this slide is really a personal reflection and summary of what I felt helpful in facilitating a smooth and fluid transition. Most importantly, in my mind, is the importance of using a developmentally approach to care that promotes a young person's emerging autonomy. As Peter has discussed, a holistic approach in the setting of transition should really address a number of key items of adolescent development, which may include the provision of mental health supports, nutrition, exercise, education, vocation needs, and sexual health. In addition, identifying vulnerable populations is particularly important, as these are the groups where transition requires the greatest facilitation and support. Promoting flexible and individualized systems that particularly empower self-management has been helpful to facilitate a smooth transition. Setting expectations early and prior to transition can be extremely helpful, as emerging in a number of non-oncology settings, joint pediatric adult clinics prior to transfer, or alternatively, and more commonly in the oncology sector, is specific transition clinics, which can help facilitate a fluid process. An area that I think is really important and often not highlighted is really creating partnerships between patients, their parents and supports, pediatric and adult specialty services, and primary community healthcare professionals. In order to do so, it's helpful to identify an adult champion who can take responsibility and ultimately facilitate the gradual movement across the sector. However, greater than this is the importance of creating proactive and deliberate pediatric adult collaborations and relationships. In the oncology space, we have created a number of craft groups, which is a framework for regular and facilitated discussions between pediatric and adult oncology relevant to particular tumor streams in the AYA years, and really harmonizes treatment standards, trial opportunities, and extends to models for transition. And building on this is really the simple things such as cross appointments for both pediatric and adult oncologists and regular attendance at cross-site MDNs, which can help foster these relationships. Also key has been highlighted previously is early primary health engagement, as most individuals will likely not need to come to an acute hospital environment, and as most of you will acknowledge, clear transition summary documents. But most importantly, which I face within adult healthcare, is really we need to train the workforce with regards to the core competencies required to facilitate quality care for young people. This is more broader than those seeing transitioned in that setting. It's important to ensure that all individuals involved in the delivery of healthcare for young people are supported with the appropriate education and training resources that enable the delivery of adolescent-friendly healthcare. Thank you.
Thank you, Jeremy. Thank you. That's a really important area, obviously. I'm going to really quickly just touch on a project that I've been working on. So bear with me 1 second, just sharing my screen. Okay, so last year the PICS commenced a service review of our long-term follow-up programme. So just going to give a brief overview. The purpose of the project, as you can see, was to review the current programme and recommend a future model of care. The reason for this review is that the programme has been around for over a decade now, and it's obviously important to check in and see how things are going. And survivorship is a key area of the new cancer plan. The programme involved, the project, sorry, involved lots of different elements. We did some internal mapping of our processes and systems. And we did lots of engagement with families and did a survey and a workshop. We facilitated consultation with all the stakeholders who engaged with the programme, and we did an international review with a subject matter expert in the US and a workshop with paediatricians and GPs, and looked at lots of data as well. The consumer consultation was crucial to this project from the get-go. And here's just a quick slide to sort of highlight some of the feedback, some of the things that families were telling us was important. We got lots of really positive feedback from the review, and but they did highlight some areas for improvement, for example, after completion of treatment and before entry to the programme, some gaps in communication, resources and support, and that families want an empowering programme and help in advocating for themselves and others. Quick overview of the findings here. The review brought together a lot of voices and a lot of feedback, but as Peter mentioned, the guideline-aligned, risk-stratified, multidisciplinary approach is best practice for this cohort and is really valued by families. But as mentioned, we have identified some gaps. When we looked at the data, we could see that the service is rapidly growing, and we've actually been at peak capacity for a couple of years. We know we need to provide improved case management for our more complex patients. Therefore, moving into the future, sustainability really is key. We know that shared care internationally is an agreed model for low risk, lower complexity patients, and Peter touched on that. So we want to explore that further in collaboration with our stakeholders. And collaboration, there's that word again. So the review highlighted that collaboration across the children's cancer centres and specialist services is obviously crucial to facilitating that best practice care. So that's working with, you know, departments such as fertility and endocrinology who have joined us today. In total, we came up with 37 recommendations for implementation, and we've grouped those across 11 focus areas for change. As you can see, there's quite a lot of work to be done, some quick wins and some larger scale service improvement projects, such as developing a shared care model and redesigning our research database. So lots to be done, but some work has already commenced. What can you expect in the future from the programme as a healthcare professional? A model focused on empowerment, focus on data collection and research, guidelines, improved communication, educational resources, more shared care, more visibility and transparency in our booking system and how we operate, and collaboration with other projects, especially in psychosocial and research areas. I won't dwell on this too much as it's quite involved, but this is just to show that we have been developing diagrams, you know, the long-term follow-up programme on the page to try and explain the model of care and pathways. And I just wanted to highlight that this review has been holistic, and we will be implementing recommendations at all stages throughout the pathway. So from transition in to transition out. So a lot of work coming. We'll be disseminating our report soon. and also these documents. We'll be coming up with a plan for implementation and continuing to monitor against that. And we'll continue to work with all our stakeholders and with families. So thank you very much to everyone who's been involved, especially during these trying times. A big thank you to everybody, including families who have really steered this project in the direction that it's gone in. And really, that is it from me. Just so you know, there's resources on the website, and we also have a YouTube channel. I'm going to stop sharing now, and apologies for overrunning.
For that, Hannah, I'm just going to quickly whiz through a couple of resources that we have on the ACSC end, and then we'll be all wrapped up. So I really wanted to make sure we got to talk about this today. A survivor story that's recently been published on our website. Our wonderful consumer representative, Meg Rinderman OAM, has brilliantly penned many survivor stories over the years. And recently Meg met with Kylie and Tilly Pretty, and Kylie was diagnosed with acute lymphoblastic leukemia when she was 3.5 years old. She's now 18 years old, and Meg learned about Kylie's experience as Tilly's carer, and also heard from Tilly herself as to what she recalls from that time. Meg, as I said at the start, Meg, Kylie and Tilly are all in the audience today, and we really thank you for generously sharing your time and your story, and I know this will be a wonderful resource for people to look at and reflect upon. So I do encourage everyone here today to visit our website. The link is on the slide there, and to have a read of this story, which is titled "Some Days It Was Really Hard." Just to flag that our website, the ACSC's website, is petermac.org/cancer survivorship. We have a range of education courses, professional development events, as well as consumer resources like fact sheets, resources in other languages, as well as a page dedicated to support for young people, which has been endorsed by the Youth Cancer Action Board. So go and have a look at our website and see if there's any resources that might be of interest to you. And just finally, I wanted to take this opportunity to mention that the 4th Victorian Cancer Survivorship Conference is taking place in March next year as a hybrid event, and our conference theme is Shifting Gears, Rethinking Survivorship. Professor Smita Bhatia is one of the international speakers that we're really proud to host from the United States of America, and she's a paediatric hematologist who's extensively published and heavily involved in the childhood cancer survivorship study, so some of you may be familiar with her. You can now submit an abstract and register for the event. So please go and check out that website. So that's it for our webinar. Apologies for going over time. We would love to hear your feedback and what you thought of this webinar. There is a QR code on screen that you can use with your phone to access the evaluation form, and I believe Amy will have also posted a link to that form as well as the survivor story in the chat. A big thank you to all of our expert speakers that joined us today. You all provided really insightful presentations, and I'm sure everyone found them very valuable. So thank you to all of you. And of course, thank you to Hannah at PICS for hosting this webinar with me. We hope you all enjoyed it.
Thank you, Tegan.
Thanks.